think we're good to go. Welcome, everyone. My name is Matt Graves. We're going to talk about Pilon fractures tonight. So thanks for tuning in. So we got a great faculty again. I think we have one of the best, if not the best, ring fixator surgeons for Pilon fractures, and I can say the exact same thing for staged plating, or in this case, I asked him to talk about something a little bit unusual, which is nailing of Pilon fractures. So it's going to be really easy for me because I got great faculty and we're excited to have the opportunity to talk to you about these things. Here are the disclosures. They're in the slide. I'm not going to spend a lot of time on any of this opening stuff because I know you want to get to what we really want to talk about. There is a webinar coming up on December the 15th on stable pelvic ring injuries, which one needs surgery. So tune back in for that. All right, let's talk about Pilon fractures. At the end of this webinar, which is going to be approximately an hour, I want you to be able to apply the theory of column stability to recognize fractures and soft tissue patterns that require alternative surgical techniques, and to consider alternative definitive stabilization techniques, including IM nails and rings, and to consider when one might be better than the other. So you will notice Pilon fracture is a big topic. There are a lot of things that we are not covering in this webinar. I want to turn your attention to this. So over the last 5 years, we have talked a lot about Pilon fractures. So we've had a webinar about every year, and there's some links here so that you can see the different focus that we had each year. So you can tune in to these other webinars by watching this, copy and pasting the link, and you can get to all different types of things, like focus on radiographic anatomy and construct failure, focus on errors, focus on pattern sequencing and recognition. So there are a lot of different things that we've talked about over the years, but tonight is going to be primarily talking about stabilization of Pilon fractures. And so while the AO generally teaches staged plating of Pilon fractures, we're going to talk about intramedullary rotting and rings as well. And so this is the outline that we have for tonight. I'm going to start and talk a little bit about plating. So at the end of this lecture, which is going to be about 10 minutes, I want you to understand column stability as it relates to plating. I want you to understand which surfaces are available for implants based on your approach, your surgical approach selection. What can you actually get to? And I want you to recognize the concerns for multiple surgical approaches. Now, this in itself could be a topic that lasted well over an hour. So I'm going to go through a fair number of slides, some of them relatively quickly. You will get a video recording of this. If you have any questions, go to the Q&A box and type them there, and Tracy and Dave will answer them for you. But you may need to watch this more than once, and you may need to go back to some of the links that I'm going to provide to get where you need to go. Let's talk about column stability at the very beginning. So column stability is not a new concept. So this has been around for the upper extremity for a long period of time. It was probably first discussed really in the distal humerus area. It's also been discussed in the distal radius area, but we talk about it in the lower extremity as well. And so there has relatively recently been papers on column stability as it relates to the tibial plateau. And there has actually been a paper relatively recently about column stability as it relates to the Pilon. Now, we've been talking about column stability with Pilon fracture treatment well before this paper came out. But if you want to look for something that'll give you a little bit of better understanding, this is something to look at. So there's a medial column. The lateral column is really the fibula, and then there's an intermediate column, and that intermediate column is often divided into an anterior and a posterior part. So as we discuss this concept tonight, that's what we'll be talking about. Now, it's possible to subsume fracture loading into 3 different categories: compression, tension, and shear. But I find it a lot better if you break it out a little bit more and talk about it this way. So compression, tension, bending, and torsion. If you think about structural elements in structural design and engineering, columns are what are loaded in compression. And so when we talk about column theory, we're talking primarily about compression, but that's an oversimplification. So the mechanical axis of the tibia and the anatomic axis of the tibia are collinear and almost the same thing. They're right next to each other. But when you introduce lack of intrinsic stability or altered muscle forces or any mechanical axis deviation secondary to that patient's anatomy, all of a sudden you get away from pure compression into something slightly different. And so you get into column deflection, which is also called buckling. And so what this means is with compression, the column starts to bend in one way or another. And that's really what we're talking about when we're talking about column stability and Pilon fractures. If you stabilize only one column or even two columns and you don't stabilize all of the columns, what is the likelihood that that's going to fail? So there are a lot of assumptions when we talk about this right now. So I want you to recognize that. But when I say that the surfaces that you can plate are related to the number of incisions that you make, I think that's a fair statement. So there are some incisions or surgical exposures that you can make that will allow for more than one surface to be plated. But in general, the number of incisions that you make is going to be directly correlated to the number of surfaces that you can plate. Similarly, the number of surfaces that you plate is going to be inversely correlated to your ability to maintain blood supply. That has two different implications. First, that has an implication for soft tissue healing and therefore infection, wound healing complications. It also has an implication with respect to bone healing because you're taking away more blood supply the more surfaces you put plates on. All right, and so I'm not going to take credit for all these cases. Some of them were sent to me, but this is not a good job, right? This is a valgus axial load fibula and a valgus axial load pilon, and it was plated medially through a medially based surgical exposure, and the lateral column wasn't stabilized. And as you see, you get drifting of the articular surface, or the relationship between the articular surface and the shaft, the lateral distal tibial angle. Now, this is somewhat expected. There are reasons that something like this could happen. There may have been an open wound over the fibula that prevented a surgical exposure. But in this case, I think it makes sense that this is not the ideal way to mechanically stabilize this injury pattern. I will take credit for some of the cases that I'm about to show you, though, including this one. So this was a patient that I made the decision to put an anterolateral plate on. Now, if you look closely at the injury films, even though they're rotated clockwise more than they should be, if you rotated them counterclockwise, you would see that this is more or less a varus failure fibula. The tibia or the talus is extruded medially slightly. And so a laterally based implant is not the ideal implant in order to resist this failure mode. I thought that through an anteromedial surgical exposure, I could anatomically reduce the column so that the medial column would bear load. But in fact, you can see pretty clearly it did not. There wasn't enough intrinsic stability here in order to prevent failure, secondary to not respecting the column theory of stabilization and not recognizing the mechanics of the original injury film. So this was my mistake. This one's a little bit different. So this is a case that I did as well. This is an open Pilon fracture. It's a valgus axial load. You see the talus is extruded laterally. There's a lot of comminution of the lateral column and the intermediate column, both anteriorly and posteriorly. And so at the initial surgical intervention through the open medial wound, tension failure wound, I debrided, made a fibular incision as well, posterolaterally, and then I fixed the medial column and put him in an external fixator with the intent of returning to the operating room to be able to stabilize the intermediate column, to be able to put on an anterolateral plate. And his soft tissue, oddly, never recovered enough in order to allow that to happen. He never lost his swelling. It was a really interesting case. So I delayed and I kept him in an external fixator for a period of approximately 3 months, and I took him out of the fixator and I thought things were going to be okay. But you see on the far right-hand side, things were not okay. So as he began to bear load, the shift in the mechanical axis made a significant difference, and the lack of stability in the intermediate column led to a fracture through a previous fracture plane along the medial column. And so this one is more understandable based on what I was dealing with soft tissue, but this is a great example of failure of columns. There's another open Pilon fracture, and you'll find that our problems with column plating often happen with open Pilon fractures. So this is another open Pilon fracture. There was a posterolateral open wound. This is a valgus failure fibula if you look at the position of the talus with respect to the tibia, but it's a segmental fibular fracture pattern. You might not recognize a distal fracture. It's not a comminuted fibular fracture pattern. It's segmental with simple patterns. But I made the decision not to place an intermediate column plate secondary to a wound that she had that I felt would be problematic for me. I don't like to place plates under open wounds, and I felt like this one was going to be problematic. And so I put a mini fragment plate on the anterior portion of the tibia and the intermediate column anteriorly. I put antibiotic cement in. I went back in and grafted her. At the grafting procedure, I did not plate the intermediate column. I regret that. You can see she's starting to drift, right? So she had to have another surgery because of lack of intermediate column stability in a Pilon fracture. Something that could have been predicted from the mechanics at least reasonably well. Now, granted, we make decisions sometimes that we feel are best based on soft tissue patterns or based on patient characteristics. And in this case, it was a wrong decision mechanically, as you can see. All right, so I think we have a better understanding of column stability now. Why we talk about the intermediate column, the medial column, and the lateral column. Why we look at the injury films and we look at the patterns that we're seeing of the fracture. What is failing in tension? What is failing in compression? Where's the comminution? Where's the talus? Where should the buttress implant be? Is it possible to place the buttress implant in that position? So I'm going to quickly go over which surfaces are available for implants based on your surgical approach selection. I put articles here for you to go back through this and look up in your spare time. If you want to look up better surgical exposure articles, I'm going to do this through cases. And so we're going to talk initially about the anteromedial surgical exposure, which is medial to the anterior compartment. There's a nice article on this, which goes over the conventional anteromedial approach and the modified anteromedial approach that you see there on the right-hand side of the screen. It gives you remarkable exposure. It is extensile proximally. You can see the entirety of the joint. So let's go through a case. So this is a 62-year-old female, status post car wreck. She's had a gastric bypass. She has anemia and depression. She has a closed 43B. I say B because this is a partial articular. The anterior part of the articular surface is still connected to the shaft, albeit impacted. And then she has posterior medial talar extrusion. Mechanically, the ideal position of an implant would be posteriorly and medially based on this. The problem with that is it's difficult to visualize the posterior it's difficult to visualize the articular surface of the posterior surgical exposure. And so we made the decision to not go to the most mechanically ideal position for the implant in order to make the compromise of allowing us to see the articular surface, to be able to deal with the impaction and know that we got it right. These are compromises that you'll make. Again, your column stability decisions will often be related to soft tissue or to desired visualization of the articular surface. So in this case, we made the decision to go anteriorly. An anteromedial approach allowed us to slide a clamp around posteromedially to get the posterior portion where we needed it to go, to reduce the impaction under direct visualization to see the articular surface, to place plates in place. And here's follow-up. So stability was maintained with this surgical exposure, despite the fact that we went to a less than ideal anatomic position for the mechanical stability of this injury film. So anteromedial exposures allows for anterior or intermediate column plating anteriorly and medial column plating. You can place both through that incision. Now let's go to the intralateral surgical exposure. It's lateral to the anterior compartment, which all gets mobilized medially. Nice approach on this, which was written by one of our faculty members tonight. It allows for visualization distally of a relatively short segment of the distal tibia and the articular surface, and there can be a separate anterolateral exposure done more proximally, which allows for visualization of the shaft. The dead zone that you see there can be visualized if you want to dissect out the neurovascular bundle and protect it throughout that portion of the surgical approach. But in general, when we talk about the anterolateral surgical exposure, we make two separate exposures, one distally, one proximally. The problem with that intermediate zone, and this is something that we can't cover, but it goes back to angiosomes, and I'm going to give a link to that later on in the talk. There is a perforator artery from the perineal that supplies blood supply antegrade oftentimes to the anterior tibial artery, which is often injured in Pilon fractures. So it's kind of a zone that you don't want to get into. What that means, and in this case, I'm going to go through something that's often combined with the anterolateral, which is the posteromedial surgical exposure. There is a proximal and a distal posteromedial surgical exposure. Proximally, it's right between the posterior border of the tibia and the tibialis posterior. Distally, it can be an interval you want it to be in. You don't have to make a long posteromedial exposure. You can make separate windows if you choose to do so. The anterolateral works nicely with the posteromedial, and that's why I'm combining the two right now. Here's a nice article on that you can learn more about the posteromedial surgical exposure. But it gives you visualization diaphyseal posterior of the shaft, and then distally the posterior aspect of the cortex of the metaphysis and the epiphysis. Not great visualization of the joint at all. So here's a case. that I chose the intralateral and posteromedial exposures. And you can see what you can get through those. 29-year-old MVC, no past medical history, 43C, diaphyseal extension of an articular fragment, anteromedial talar extrusion, and a simple Weber C fibula. And so at her first surgical intervention, she was placed in external fixation by one of my partners. And what you'll see is if you have a simple spiral pattern that extends proximally and you leave them in external fixation for any prolonged period of time, it's very difficult to get that simple spiral fracture anatomic at the next stage of the procedure because you have to take down a great deal of soft tissue in order to do so. So oftentimes what's advantageous is to do something posteromedially proximally in this situation. And so we took her back early after that because that approach is almost always allowable early on. And so posteromedial proximal incision allowed visualization of that spiral fracture pattern proximally. We could have placed a plate posteriorly, but in this case, we just used independent screws. We fixed the fibula through a separate surgical exposure. We kept her in the external fixation, awaiting her definitive treatment. We got a CT scan. We went back through the anterolateral surgical exposure. It allowed for intermediate column plating anteriorly with the anterolateral plate as well as rim plating, and we put a medial column screw in place. And so through a posteromedial, you can place plates posteromedially. That's about all you get. You can get a little bit of medial column exposure through the posteromedial, but it's a little bit dangerous to dissect to anterior through that because that's a dead zone for soft tissue in terms of angiosome. So you got to be careful trying to dissect to anteriorly through a posteromedial approach. Through an intralateral exposure, you can get anterior intermediate column plating. If you would like to place a medial plate, you're going to have to make a separate small medial exposure to plate the medial column. Oftentimes we will use column screws in a scenario like that, which is what you see here. We try to get those bicortically because they provide much better support. All right, we're going to go through one more case. This is a posterolateral surgical exposure. We talk about the posterolateral incision for fibular fixation. When we say that, we're really talking about going anterior to the perineals with a posteriorly based surgical incision. This is different. This is the posterolateral surgical exposure, which is between the perineals and the FHL. There's a nice article on that where you can learn more about the posterolateral surgical exposure. It gives you visualization of both the fibula and the posterolateral portion of the tibia. You can get to the posterior tibial tendon groove posteromedially through this approach fairly well. You cannot get a medial plate on through this approach. And so here's a case choosing a posterolateral approach early on. 32-year-old MVC, he's got some drug and alcohol problems, 43C3. Valgus and posterior extrusion of the talus and a relatively simple Weber C fibula fracture. So we initially went posteriorly. That allowed us to stabilize the fibula and fix the posterolateral segment of the joint, put him in external fixation, subsequently came back for an anterolateral surgical exposure for intermediate column anterior plating and medial column screws. But that posterolateral exposure allows for both fibular or lateral column plating as well as intermediate posterior column plating. Very hard to get over the medial column through that surgical exposure. All right. So now, lastly, recognize the concerns for multiple surgical exposures. If you're doing enough Pilon fractures, you're going to see some plates in your clinic through the skin. That's not good. None of us like to see this. This is the legitimate risk. This is the thing that really makes your heart drop when you're in clinic at the very beginning of your surgical practice, or even later than that. It's a terrible thing. There are two issues we're talking about. One is risk of wound healing complications. I think that's nicely described in this study. So the 7-centimeter rule is more of a dogma that we really don't go by. We do make surgical incisions closer than 7 centimeters away from each other. That can be safe. There's a lot we still don't understand when it comes to the soft tissue around the ankle and its vascular supply. Realize you can do this. You have to be extremely careful with the soft tissue if you're going to do this. There's also the issue of blood supply to the bone itself, and does a staged posterior exposure or multiple exposures lead to an increased risk of non-union? This study really isn't powered enough to be able to show that there is a definite problem with non-union from a staged posterior exposure, but it does at least make us concerned. That's logical. You should be concerned. There should be a good reason that you're going in the back if you're choosing to go in the back. So those are the two things that we have to think about. I'd like to tell you about another webinar that we did on soft tissue where I talked a lot about angiosomes and using a Doppler for decision making around the ankle. We don't have time to talk about that now, but I do want you to, if you have time, go through that, because there's a lot that we're still trying to figure out in terms of why some patients still have soft tissue complications, even with ideal soft tissue technique and good surgery. So as final recommendations, in terms of plating for Pilon fracture management as a function of stability, when there is a tension failure side, a simple transverse fracture pattern typically, bicortical column screws are probably better than plates, or at least just as good. It's not as important that you have a buttress plate, which really isn't going to be functioning in buttress mode anyway, on a tension failure side. You can use a very small plate if you choose to on the tension failure side, and it'll work well, or you can consider bicortical column screws if you can reach a second cortex. I think, at least in my experience, intramedullary screws are not ideal at resisting problems. And oftentimes when they bend off the lateral cortex, they create some valgus. So bicortical screws better. When there's a conflict between either articular visualization or open wounds or soft tissue and buttress plating, you need to be looking at the amount of impaction and the cortical reduction reads, as well as pre-existing alignment and the size of the patient. What I mean is there's a consequence for every choice you make. If you have a simple cortical reduction read and no articular impaction, you can make the decision to choose to be in a less ideal place mechanically in order to take advantage of articular visualization. Or you can make the decision to be in a less ideal place mechanically in order to prevent placing plates underneath open wounds or soft tissue problems. And so be thoughtful in terms of when you're deciding to plate a specific column. And when plating isn't enough, we're going to talk about augmentation or alternative stabilization options. And that's what Dave's about to do. And that's what Tracy's about to do. So thanks for your attention. And I'm going to turn it over to Dave now. So Dave, I'm going to stop sharing.
Thanks, Matt. I hope that's all working out okay for everybody.
Yeah, it looks good.
Okay. You know, Matt, that's a hard act to follow because it's so incredibly comprehensive, and it's awesome for me to listen to. So I appreciate being able to be part of this webinar and learn from of course, Tracy and Matt. Matt asked me to do this, and I kind of had to scratch my head a little bit because you know, nailing is not something that comes to my mind when I think of the Pilon fracture. When I think of a Pilon fracture, I don't think of nails. But as I started kind of going through this and started thinking about, well, you know, why not? And then I started going back through some examples and started to think about it a little bit more. And I'll just share some of these cases with you, and hopefully it segues nicely or meshes nicely with Matt's talk about the consequence to everything that you do, and around Pilons, it can be substantial consequences, both good and bad, if you make the right decisions versus making sometimes the wrong decisions. So I'll just lead in with some cases. This is a 53-year-old gentleman. He's on Coumadin for a mechanical heart valve. His R&R runs, you know, between the 3 and 4 range. And of course, what you do when you're on Coumadin with mechanical heart valves, you get up on a ladder. And so then he of course falls down. He's got an open anterolateral aspect of the distal part of his leg. I'll just leave that up for a second for y'all to have a look at it. Here's case number 2. This one's a 61-year-old fella. He also likes to be up on a ladder, and he enjoys the occasional cigarette, but otherwise he's a healthy guy. He's got an open medial wound at the supramalleolar level. And the thing that's interesting about him is that he's transferred from an outside hospital because he has absent pulses and a CTA demonstrating no flow of any significance at his intertibial artery dorsalis pedis level of fraction, and there's no reconstitution. He's got a part of his posterior tib occluded, and his foot is a little bit mottled and purple and poor capillary refill. And he comes to us with no real good palpable pulses and a small posterior tibial Doppler signal. And the vascular surgeons say there's no revascularization options for this person. And then case 3, 25-year-old female. She's got some mild CP. She unfortunately uses a little bit of methamphetamines, and she jumps from a 4-foot high height, resulting in closed distal tibia fracture that you see there. So I'll start off by saying that nail and pilons, is not my preferred method of treatment. I'm a plate guy. I'm a stage plate person that really tries to respect the column stuff that Matt has taught us. But like most fracture stabilizing devices, nails have a place, and I think you're going to learn that with Tracy too. That these alternative devices can all play a role in treating certain fracture patterns or certain fracture situations. And what can a nail do, right? Well, it can support epiphyseal metaphyseal alignment, more commonly metadiaphyseal alignment, and we think of it for that zone. And it can maintain a patent medullary canal, and sometimes that's very helpful for subsequent procedures. I think compared to plating, it can minimize risk to the soft tissue envelope. And I think in regard to pilons, I think the pilons that I'm showing, it's used as an adjunctive stabilizing implant, certainly not used in isolation. It's not used for me to stabilize or something that's going to stabilize intra-articular fracture lines on its own. It's not going to be used to buttress or stabilize disimpacted articular fragments. And it shouldn't be used because it's easy or familiar to any of us. And I have pretty good successes with plating, but there are definitely some fracture patterns that I worry about. And I think what I've tried to think about is, like, well, when do I pull this nail thing out? And I think C-type injuries with metadiaphyseal comminution, people with bad soft tissue envelopes, are people that are poor, relatively poor hosts. And if we look at, what's good and bad about plates and nails, and there's been a little bit of work, of course, trying to figure out whether the consequences of plates versus nails for distal tibia, albeit these are extra-articular distal tibia fractures. I think we go down here, the nails generally compared to plates for this location, I boil it down to this, you got to be careful because it's easier to malalign people with a nail. But plates, while I can get them lined up a little bit better, I have higher wound complication rates. And so, these are the things that for me, there's all that other stuff, but these are really the consequences and the trade-offs and you're trying to make. And I think that we wouldn't even be talking about this unless there was some evolution in the implant. I think, not so long ago, nails had a certain, pattern of distal bolts placement. And then as it's evolved, we had multiplanar options. So bolts going in different directions, they all kind of got pushed down the nail a little bit. So you could start nailing really close to the tip of the nail. And the tip of the nail could then be put more distal towards the articular surface. And then more recently, having the ability to create some sort of fixed angle of your interlocks distally, either with inlays or with tabs or implant designs. And I think for me, one of the best things to help with this kind of thing is how you put it in. And I think that the nailing, of course, with the knee not having to be flexed in the suprapatellar approach, I think also has to be put into that category of a nail evolution that's allowed this to be even considered. At least for me, it is. So, we thought about nail evolution, then let's think about fracture patterns. I think one of the most important things is that you need to have a distal tibial epiphyseal block or be able to create one that you can nail into. And so if I look at these two things, these two injury patterns, we've got the one on the right, which certainly doesn't scream, yeah, put a nail in that one at all. That looks like a terrible pilon to try to do anything other than plating. Whereas the one that you see on the left, it's more of a cleavage injury or separation injury. There's not a lot of impaction. That one, maybe you would consider if it had metadiaphyseal extension of significance that you could maintain that with a medullary device. And of course, what's different about these fractures is, as you get more and more distal, the nail starts to swim more and more in the distal metaphyseal cancellous bone. And now if you add on top of that, the cancellous bone has now been fractured, well, that just creates even more challenges to put the nail in the right place. And so the nail is small relative to the distal tibia. And of course, then you get closer to the ankle joint, perhaps there's some amplification of the bending moment, which can create further instability. And so the challenge is to obtain and maintain that reduction with these devices. So you got to know your nail geometry and where the location of those bolts are. It's really advantageous if you're choosing a nail to do this kind of job that you have multiplanar interlocks, because you may not be able to use some either because of other implants or other fracture lines, and you want to have those options. And if you use those options in a multiplanar fashion, it also creates stability. But you're not going to rely on that, or at least I'm not going to rely on it. So I'm going to have multiple techniques that I'm going to use to obtain stability. And then I'm going to go to the CT and really start to understand where there's impaction and where there's bending and twisting mechanisms that create articular fracture lines. I'm going to be able to try to figure out and sleuth through those things to try to understand the best way to approach the articular surface, because I'm going to prioritize that articular surface. I think this has well been figured out, that the nail doesn't reduce the fracture. And I certainly can say that 20 plus years ago when I was a resident, that was my understanding, that the nail would reduce the fracture in anything but an isthmic fracture that got a malreduction. Just didn't understand why that would have ever happened. And it's kind of painfully obvious now that anything other than isthmic fractures, the nail can't do that. And so you have to do that. You have to reduce the fracture and maintain that reduction and place a nail across a reduced fracture and then lock it distally with that fracture reduced. And I think this is just a nice graphic example of a nail in the same spot, but you can see how it just toggles around that distal segment. And so if you now couple this with comminution, you couple this with intra-articular fracture lines, I think you can see that becomes a big problem. So for me, reduction and stabilization strategies for the distal tibia are, I think, as I think about them, these are the ones that I think about, fibular reduction in temporary plates or definitive plates, even clamps and shan't pins and external fixators and blocking screws are all reduction and stabilizing strategies that can be both helpful with reduction, and some have dual purposes, as the ones you see circled here, as both a definitive stabilizing strategy. So let's go back to the cases now. And so here we have this 53-year-old guy with the INR of 3.5, and he falls from a ladder, and he's got an open intralateral distal tibia fracture. He's got a relatively high fibula fracture, and he's got a lot of metaphyseal comminution. He's got a large amount of impaction in the anterior and central part of his plafond. The night he comes in, he gets a single incision 4-compartment fasciotomy. He gets a provisional plate, which you can see there's a bunch of screw holes there. It was ultimately revised because it was malrotated, but he gets his fibula fixed and he gets spanning external fixer. And I think there you can see his articular injury, which I would call a real pilon, and he's got comminution. He's also got pre-existing arthritic changes of his midfoot and of his tibio-talar joint. And this is him. And so for me, this guy is a big concern. He's got circumferential hemorrhagic blisters, but he has viable musculature. And I'm really concerned about this guy having a complete failure of his soft tissue envelope. And so for me, I thought, well, I can try to go ahead and C-type injury. I should plate him with multiple column fixation, but the cost of that might be really bad. It might cost him a serious soft tissue infection. Then he's got to have his leg off because his mechanical valve is not going to tolerate getting seated either. So this fellow, I worked entirely through his fasciotomy wound, which was brought all the way down to the tip of his fibula and then some. I ignored his medial malleolus, and working through his fasciotomy wound, we used a small plate to neutralize the articular surface, create a block, if you will, of that articular surface, prioritize that. We go ahead and get his alignment with our external fixer, and then we can go ahead and put a medullary device down. And this was one of the first times I had ever done this. And I think this was a number of years ago. And he ultimately goes and gets bone grafted, but it took him forever for his soft tissue envelope to heal before I could bring him back and bone graft him. And then here he is 3 years post-injury with his healed, infection-free, good soft tissue envelope and an adequate tibio-talar articulation. Case 2, this is a guy that's a little bit more recent for me. As a matter of fact, this is the one I made the mistake of sending to Matt just to see what he thought about it. He said, why don't you do rotting for pilons? And here it is. So this is a 61-year-old fellow, falls from a ladder. He's got no medical problem, but he smokes. And so he's the one with this vascular injury, and there's no vascular revascularization options by the vascular surgeon. So they said, good luck to you. If it works, it works. If not, there's nothing we can do. So once again, big worry about wounds, big worry about healing. The more I disrupt and disturb, maybe I'm going to knock off that last little bit of blood supply. He's got this particular injury pattern. My colleagues are on call that night. Here's his leg. He's got this open wound straight on the medial side. He's got a little bit of modeling of his foot. Okay, we do the best we can. In an effort to minimize insult, he gets an application of external fixator to restore his length. He gets an IND of his open wound. He just gets a small direct lateral incision over his fibula, basically to realign His fibula enough to put a medullary implant through his fibula. Clearly not rigid fixation, not anatomically reduced, but pretty darn good. And everything is working towards stabilization of his entire distal tibia without insult. Try to do no further harm to this whole thing. And then he goes to the ICU for circulation checks and warming and some aspirin. And of course, his leg perks up and everything is pretty good. And so here he is for me now. And here's his injury. So not a bad plafond injury at all. He's kind of got a lot of that lateral part of his plafond has been injured, but a lot of his plafond is intact. So I'm grateful for that. And there you can see his 3D reconstructions. I thought kind of give you the lay of the land a little bit better than any sort of simple axial cuts beyond that. So my surgical thinking for this guy is that the fibula is not going to be terribly useful for providing stability. Certainly not in terms of stability like the rigid stability that I had maybe gotten from that previous case. I also thought his articular injury isn't bad. He's got substantial metadiaphyseal comminution and a C-type injury pattern, which for me needs multiple column stability typically. And I felt that unicolumnar plating, even lock plating, was insufficient for maintaining alignment or stability towards union. So I didn't feel like an anterolateral locking plate would be sufficient. I didn't feel like an isolated medial plate would be sufficient, certainly not with that injury pattern, the way it happened in valgus like that. And so I was worried that I would need 2 plates. So I really worried that dual column plating would present significant soft tissue risk and problems, and that I still didn't want to be the guy that tipped over his vascular situation to the negative and he ends up having a serious complication. So for him, I decided to use this as an adjunctive technique. I did an anterolateral exposure, which you can see in the distal red line right there, to access his articular surface, his syndesmosis, and through that place an retrograde anterolateral plate. And then through a more proximal anterior exposure, I could access some of his metadiaphyseal fracture fragments, help with placement of the intralateral plate, and of course, help with his metadiaphyseal reduction. So here, using those same principles, we're gonna get his joint pretty good. We're gonna reduce his syndesmosis with that big Chaput fragment, bring it on over. His posterolateral skin is terrible, and as much as I would have wanted to get at his Volkmann fragment posteriorly, it just wasn't happening. So I wasn't gonna be able to manage that directly, and it was hard to manage that through the incision. Fortunately, his Chaput fracture fragment behaved really, really well for me to get his syndesmosis back where it belonged. Neutralizes articular surface, and then using those other tricks, including a good periarticular implant, we're able to reduce him and then bring a nail down to help neutralize what I think is the medial column of his tibia with an internal device like a nail. Last case that I presented earlier, here she is. Once again, metadiaphyseal comminution. She's got significant Pilon impaction. These are not simple spiraling fractures like a posterior malleolus that comes from a spiral distal tibia. I think this qualifies as a real Pilon, a C-type injury. The plate is placed on the fibula and fixed rigidly. And then once again, using the same principles, we're gonna go after that articular surface. A 2-column plate, probably ideal for this. Here's her CT scan. You can see the impaction. Once again, intralateral, we're gonna prioritize the joint. We're gonna stabilize the joint surface. We're going to use a plate to help stabilize this, and use the plate to help reduce some of the translational alignment. And then once again, use our medullary implant to obviate the need for what I think is a medial sided plate. And this is, very concerning for going into varus or going into some deformity with isolated unicolumnar plating. So for me, as I thought about this, I thought there was 4 critical steps in all of this, that if you're going to use this technique, you got to strive for anatomic reduction of the articular surface and secure fixation of that articular surface. That's still got to be the priority, I think. You want to restore frontal, sagittal, and transverse plane alignment subsequent to that. You're going to place your fixation implants to avoid your guide rod, your reamer, your nail, and your distal bolt collisions, right? You don't want this to have any drama in it as you're putting the nail down and pop things apart. And then you want to maximize distal segment stability. So if I go through some of these cases, this is just examples of, well, how did you get articular surface reduction and stabilization? Well, here we used a direct visualization. We brought down the front of the plafond. We worked inside the joint. Here I'm using a 2-0 straight plate and some small screws to help stabilize the distal articular surface. In case 3, we use the periarticular plate that you can see right there, same principles. For alignment, fibular ORIF, I love fixing the fibula. I think you get so much mileage out of the fibula. I love that. Fibular ORIF is always a really good one for me for restoring tibial alignment. Using external fixators, using clamps, and using periarticular plates can really help you start to realign things, and using the plate as a reduction tool. And I think here's some examples of using all of those for these pilons that you can see. Avoid collisions. You just got to be careful where you put your screws and really get things out of the way of where the nail is going to go. And so whether that's using unicortical screws, whether that's using, a careful radiographic planning and seeing where your things need to go and understanding where your nail is going to go, it's critical that you be able to avoid these collisions, or else you're going to be in for a bad afternoon. And then maximizing distal segment stability, because at the end of the day, you need this thing to hold together long enough to start healing. So using, multiplanar interlocking, distally locking nails with or without angular stability. Here we're creating a distal articular block with screws, with plates, with wires and things like that. I think rigid fibular fixation, when you can do it, is really good to help control the whole distal block together via the syndesmosis. Fibula pro tibia fixation. So once you're done, coming back to the fibula and sending it either into the tibial block, the articular segment, or going vice versa, putting your interlocks through the nail into the fibula, or fixation going from the other direction can be useful as well. I think plate nail constructs have been pretty good. And sometimes if you're lucky enough, you can link implants. And here we just managed to get one of our locking screws through the plate to duck inside one of our interlocking bolts of the nail. And that's just pure luck, but you can place the nail properly sometimes and be able to match some of these things up to link your implants. And that can give you tremendous amounts of stability. So in summary, for me, nailing pilons, it's not my preferred method of treatment, but every now and then, if you think about it, it might help you with some cases that you want to have another tool in your toolbox, and it has a place. I think it's really good for stabilizing metadiaphyseal fractures and certain epimetaphyseal fractures. And I think creation of a distal articular block is really key to that. And articular reduction has to be the priority, right? That's the long-term thing that we can't really fix easily. We can fix a varus malunion or something like that, or a non-union in the metadiaphyseal region. So the priority really needs to be the joint, and the nail can't compromise that. This is what I illustrated in the beginning. I think this is what the nail can support, that epimetaphyseal, metadiaphyseal alignments, and maintain a patent medullary canal, minimizes the risk of the soft tissue envelope. But I think I tend to use it more as an adjunct of stabilizing implant. And as I go through it, I think it really helps me instead of a medial plate when necessary. I think it can decrease the need for surface implants and help decrease the risk of soft tissue problems, but it's not simple. I think it's technically demanding, and all of your implants really need to be thought through. I don't use it to stabilize intraarticular fracture lines or do things to the joint that I need a plate and other independent fixation to take care of. And those are some fracture patterns that I worry about that I showed you. These are the ones that I think are the problems: the bad soft tissue envelopes and the poor host and that metadiaphyseal comminution. And I'm just gonna, if you work with me on this one, I'll just show you this last one. And this one to me doesn't scream nail. And she's not a good host. She's a high-speed wreck. She got bad bones, got rheumatoid arthritis. She's got an open wound laterally. She's got a contralateral pilon too, and this is the right side, and so here we are. We drag her out to length with her X fix. We fix her fibula just with medullary fixation, because I don't even know if this leg's going to ultimately be salvageable with all this. And I think you can see that her plafond is pretty jacked at the articular surface. Now I ultimately fix her with an anterolateral, and I put on her, I get her joint reduced, and I put an anterolateral plate on, and I leave her X fix on to help hold her medial column, because her skin is so thin and so poor there. I couldn't imagine putting a plate on. And she ultimately heals, and she heals with pretty good alignment. But as I was going through this, I started thinking, you know what? I wonder in this point in time if I could have just dropped the nail down into her with some unicortical screws and taken off her external fixer and simplified her treatment further with the use of a nail. And as I start thinking about this more and more, and Matt's got me kind of thinking more and more about these things, I just thought I'd show this case at the end to kind of contrast how that could have been a way to help manage this particular injury pattern without the medial column external fixators that I had on for 8 weeks there, it says, and weight bearing at 4 months. I might have been able to help her differently. And this turned out well, but just as food for thought. Thanks very much.
Dave, that was unbelievable. There's a reason I ask you to do really hard stuff, because I feel like you're primarily put on this world to teach me. But I love the fact that you're teaching everybody else as well. So thanks for taking the time to do that. That was really incredible. There are a couple of questions, one of which, because it's your case, I think it would be appropriate for you to answer. What was the purpose of the 1/3 tubular plate over the AP interlock on the case? Yep.
I was so concerned about the whole thing just coming apart.
Yep.
That all I did was I just kind of used, I think it was just a 3-hole 3rd tubular plate, and then put screws and then the interlock through it. And so basically it was just another way of almost like rings around a barrel, just kind of hooping the whole thing together. And that's all it was. It was just kind of like trying to figure it out.
Yeah, I think that's a great technique and useful for metaphyseal nailing procedures. And I've used it a number of times as well, with that plate or other plates. And it's nice to help to stabilize the distal segment or the proximal segment if you're doing it for a subtrunk or something, in order to keep it in place. Yeah. One question about linking implants. It seems like a sexy trend that looks good and feels nice, but if one portion of the fracture fails, then it could compromise the whole construct. What are your thoughts?
I think it really helps rigidity and stability of your overall construct. And I think it's just one more strategy. And I think that it's good. Do I think it's necessary? No. Do I think that you should compromise something else for it? No. But every now and then, if you pay attention, you'll see an opportunity for it. And I think that's when I use it. I don't necessarily plan on it, but there are certain times where I'm ready to use it. And it's just another trick of trying to get some sort of stabilization, and I find it periodically useful, but it's not the be all for me, and it's infrequent that I do it. I'd say probably more common in the distal femur that I might link those implants. The tibia doesn't help me that much. I think fixing into the fibula or the fibula into the tibia, I use that a lot, but not necessarily with nails, occasionally.
I think because it's used primarily in the femur, distal femur, right? And where you integrate them, you put your locks from the plate through the locks in the nail. I've actually done 2 cases where I've had locks through the plate into the nail proximally, where it was totally unitized, one big device. Too rigid. It was too rigid. Both the plate and the nail broke same time, which was a disaster.
That's interesting.
Yeah. So I would caution you against making it too rigid, integrating a unitized construct both proximally and distally. Distally down below, probably okay, but I really would not unitize the whole thing, because it becomes so rigid. It was like the ultimate locked plate. Just like, when we started putting locking screws up and down these plates, they were so rigid you got no callus and it broke. Very similar to that. I had a pretty catastrophic failure, even though it looked like it was healing. Just there was no callus and it was too rigid. So I think it's a good idea, but I would avoid the temptation to lock top and bottom.
Yeah,
I think it's
interesting.
too rigid.
All right, Dave, one more question before Tracy blows her mind with rings. Is there value in reaming?
Is there value in reaming? Yeah, I think reaming alters blood flow to the tibia or to the bone, destroys the end osteal blood flow. There's compensatory hypertrophic or increase hyperemia to the periosteal blood flow, and then everything over, at least in a sheep, over about 12 weeks or so, seems to settle on down. I think reaming injures things, and I think that injury creates an inflammatory process, and that's pretty good, So I think that reaming is pretty good. If it's in the context of this, I think reaming is really good because I don't need any drama as I'm about to put down a definitive implant. And so I know that if I If I can just gently put the reamer down and make enough space and put in an undersized implant, no drama. It's going to make its way through. It'll be okay. That's another reason for me to ream.
I remember the first few Pilon non-unions that I had to deal with in practice, and I was going back and trying to plate them, and I was struggling, man. I was really struggling, and I remember calling up Dr. Benershka, and he said, "You just nail them. You nail all of them. What are you doing?" So I started nailing them, and I think there is huge value in reaming, actually, because you can get away, especially with adjunctive fixation, like small plates that cross the fracture as well. You can get away with nailing really, really distal Pilon non-unions as well. And that's when I use it more commonly, is for non-unions, the Pilon, than I do for acute treatment. But I really appreciate you taking the time going through that. I know that was a complicated topic, and that was just awesome to watch. Tracy, they're about to be blown away. Please talk to them a little bit about ring fixation.
Okay, so well, thanks. What you've seen is a pretty fantastic couple of lectures. And one thing I want to emphasize is the concepts that I'm going to show you aren't really appreciably different from the other two speakers. In fact, both previous speakers showed a problem list, and I'm going to show the very same thing. So you don't start off thinking, I'm going to put a ring fixator on this. And you don't start off thinking, I'm going to put a nail down this. You think about the personality. I mean, you've heard this a million times, the personality of the fracture. And you really have to know the particular fracture components you're dealing with in the context of the soft tissue. And so we're all three of us are talking about the same thing. So we're going to talk about the primary injury factors that would convince you that maybe this is a good device to use, acute and reconstructive indications, and some of the advantages that this has to offer. I'll start off with a pretty dramatic case, 55-year-old, and he did land in a barnyard. This was in southern Missouri, a barn raising, or in his case, a barn falling, bilateral open extremities. Significant contamination, and it was really barnyard contamination for this particular injury. Is a fairly devastating type injury. No matter what you're going to do, you're behind the 8 ball. So the key here is you don't want to make him any worse than he's already going to be. Here we're just kind of worried about amputation, so we're trying to make the best of a really crappy situation. Open wound wasn't so bad, and this is after a couple of debridements, but it was thoroughly contaminated. As you notice, everyone did a spanning external fixator. You don't just jump and put a ring fixator on these patients. Again, you want to stage all of these really complex injuries, whether you plate them, nail them, or eventually do a ring fixator. You have to really understand what you're dealing with before you jump to your final treatment montage. This is pretty standard, the other speakers talked about. We're trying to get some type of a gross reduction, putting things back with a modicum of internal fixation, lots of K-wires, just to see what we can get. In this case, the soft tissues were pretty substantially a problem with infection with E. coli and Bacteroides. So that was really the limiting factor. And you can see the joint surface is fairly toasted, and a lot of big metaphyseal fragments, however. And so this, in my mind, was ideal for a ring fixator. This was the montage after we got the wounds closed. Surprisingly, he didn't need a flap, so it was a fairly nice thing not to have to put a fixator around the flap, and a foot frame to hold him distracted to allow the joint surface to heal. This is down the road as things progress. We took the foot frame off, got him weight bearing. Soft tissues, amazing. Soft tissues recover fairly quickly with a ring fixator. 2-year follow-up and a 5-year follow-up. It ain't pretty, but at least it works. He's still got his leg, and eventually I'm sure he's going to come to a fusion at some point, but he's a southern Missouri farmer who really doesn't complain a whole heck of a lot. So what you need to look at are the particular components of a fracture and where they fit in terms of ring fixator. Articular surface, usually we do these on highly comminuted or impacted fractures that don't reduce with ligament ataxis. The capsule is detached. You have a lot of fragments without subchondral support, and distraction certainly will help this. Metaphyseal fragments are also very important. You have to look at the size. And most of the ligament ataxis pictures that you saw from all the speakers, these reduce very nicely with traction. And so that's the key for ligament ataxis. It'll reduce the metaphysis usually very nicely, not so much the small articular segments. And so depending on the size of those metaphyseal fragments, that's really going to dictate your fixation. Is it large enough where you can do a locking plate or a buttress plate? Is it small enough that it'll only take a lag screw? Or is it so small, only wires or olive wires will work? So really pay attention to the size of the metaphysis, because that's really the basis of how you're going to fix these. And it can be a plate, a nail. Now, in this particular case, I totally agree with Dave. An advantage of a nail and a ring fixator is it bypasses this kind of dysvascular, this watershed area, which is a diametaphyseal junction. Dave talked extensively about that. That's one of the advantages of a ring fixator is you get away and you don't mess with this location of major complications. If you look at a lot of Pilon series where they have problems, the joint usually heals. It's the diametaphyseal area where the wound breaks down, where they get a non-union, a malunion, and infection. Very rarely is the joint, at least initially, a problem. It's in this watershed area where there's a real problem. And so the advantage of a ring fixator is it just bypasses it. And it also allows you to, what I call massage this fracture line. You can actually actively manipulate this area. You can close down small fracture gaps. You can gradually reduce them with a particular frame. And in some instances, you can actually re-lengthen. And you can restore the mechanical axis, and you can get soft tissue closure by massaging this diametaphyseal region, much the same way that Dave just bypassed it with a nail. So we're not talking about completely opposite concepts. It's very, very similar. It's just a different way to skin the same cat. Again, with the shaft extension, especially, a lot of defects are going to occur in this area. You can do symmetric compression distraction. In the worst case scenario, you can actually then do bone transport to restore some of these larger defects. Soft tissues are always a major concern as to whether these will ever recover. And all the speakers have talked about waiting these things out, staging these procedures until the soft tissues allow. So as all the other speakers talked about, we span these, waiting for the soft tissue to declare themselves. A small wire frame will allow you to capture all very small periarticular fragments. You can distract a highly comminuted or crushed joint. The one advantage of these is you can capture very, very short periarticular segments and begin very early weight bearing, because it's like a trampoline. You can support these fragments, unlike a plate or a nail where you have to wait for some articular healing. If you capture these fragments and you span them like a trampoline, they can start to weight bear and move their ankle fairly quickly. And then in cases of significant shaft extension with bone loss, you can deal with that in a whole host of ways. And certainly these are very soft tissue friendly because you're not making very large incisions. So we'll look at a few cases and how a frame fits into this. So again, I mentioned one of the big advantages is stable fixation of very small, short segment metaphyseal fragments. In this case, this was an open injury, a big, fat, horrible leg, a diabetic. Another very similar thing. This case patient was 400 pounds with kind of a crust joint with an open wound, spanned out to length. You see a nice ligament ataxis reduction. The major metaphyseal fragments reduced very nicely. However, the soft tissues here were just not cooperating. So you have to make a problem list, much as Dave did and much as Matt did. So you're going to look at soft tissue compromise. Are you able to capture the small periarticular fragments? Well, that's a good reason to use it. Do you have a highly comminuted crushed joint and you need to distract? Yes. Is it a short periarticular segment? Yes. Do you have significant diametaphyseal extension? No. And then what about the soft tissues? Well, possibly they're a real problem. So you see a whole host of yeses here, which in my mind turns me towards ring fixator. So you have to go through this kind of algorithm with every type of a fracture. So the frames are placed with the patient in distraction. We do a temporary ankle spanning frame, and we put the rings over and around the distraction frame. So these are done with the patient's leg in a 2-pin fixator or a simple external fixator. We use limited CT-directed approaches for articular reduction. We still go after the joint surface, just like all the other speakers do. And then we use olive wires to act as lag screws, much as you would a lag screw or a plate. We have a widespread and transverse and the coronal plane to act as a metaphyseal buttress plate. Now, the problem with this is you can't put an olive wire front to back. So if you have a large anterior crush injury, a ring fixator is probably not the best device to use. Where the anterior cortex is crushed, the ankle jumps out anteriorly, and you need that anterior buttress. The problem with a ring fixator is you can, but it's not ideal. So for a true anterior buttress crush type injury, a plate is much, much better because it's very difficult to get fixation with an anterior posterior frame. You just can't do it because of anatomic constraints. And then you're going to span this with a proximal ring construct to span the zone of injury. All right, so back to this case, soft tissues were pretty crappy. I didn't even want to put an incision on, so we used one of these balloon type devices. We stabilized the fibula, we disimpact, and then stabilize the articular surface with wires, and then continue distracting the frame with distraction wires. At about 6 weeks, we take the foot frame off, allow them to move their ankle, and begin gradual range of motion. And in this case, got a really nice reduction and excellent healing of the metaphysis. Now we're starting to approach kind of the limits of what you can do. So this was a patient who was transferred to 35 days. The patient finally woke up out of the ICU coma and realized that the ankle was cockeyed and they had ankle pain. You can imagine at 35 days, the soft tissues laterally are very contracted as the soft tissues medially. So to put any type of an incision on this to try to reduce it would be fairly problematic. So again, this is actually kind of pushing the envelope, very thin articular surface, but just highlights what small wires can do. Very, very short periarticular segment, contracted and internally degloved soft tissues. It's very stiff, it's not mobile. And by the way, the patient's a diabetic. So let's just throw gas on the fire. But with these frames, you have the ability to capture very small periarticular fragments, and then gently manipulate them without open surgery. So we very carefully pass wires just through the small articular subchondral fragments. And we try to stack as many wires as we can. In this case, we got at least 4 wires in the transverse plane. And then for added stability, we put on a foot frame to help stabilize this very distal articular segment. And then gradually correct this significant valgus over 6 weeks to avoid soft tissue necrosis of the lateral contracted soft tissues, and gradually just realign careful. And over the course of time, we basically get this pretty much dialed right on, and you'd be surprised how well these heals even at 6 weeks with these kind of atrophic soft tissues with compression. We get this to heal very nicely with really no incisions at all. So we went from that to that in about 13 weeks with pristine soft tissues. Very nice demonstration of what you can do. So here again, we have short segment diabetic crush injury with horrible soft tissues and a compartment syndrome. And this is the leg that I showed earlier. I think, putting any reasonable incisions on this leg, or even with a nail, you might as well just cut the leg off. And this was like death warmed over, except everything was still alive, but you don't want to touch this with a 10-foot pole. So going through your algorithm again, soft tissue compromise, yes. Fairly small periarticular fragments, yes. The joint wasn't bad. So if the soft tissues were okay, you certainly could have put a plate, could have put a nail, you could do anything you want, because the soft tissues were so bad, this really limited you. Short segment fracture, yes, we want to start early weight bearing. Diametaphyseal extension, no, so we don't really have to span anything, but soft tissues that won't ever recover, yes. So again, that leads you down the primrose path to putting a frame on. Fairly easy frame to do. You see we've got coronal plane wires to stabilize flexion extension, as well as transverse wires. We didn't have to span the ankle because we have ample room to capture that entire segment. And very nicely, the soft tissues recover. This healed like gangbusters because we allowed early weight bearing, and a nice salvage of potentially a disastrous problem with the advantages of short segment fixation. Here again, another very, very short segment. I really feel that for very short segments, the frame can't be beat for a lot of these. And so stacking wires is really a nice way to go. We do just like you do with a plate. We try to stabilize the fibula. The fibula brings out the length and reduces a lot of the ancillary fragments in the tibia. So just because it's an X-fix, you cannot forget the fibula. Immediate weight bearing, frame off in 10 weeks with really no incisions. Now, unfortunately, we see a lot of gunshot wounds where I'm located, and these can wreak havoc basically with the soft tissues as well as the articular surface. Doesn't look too bad. We pull it out to length, but you get a CAT scan, you see there's just a big hole. There's no bone clear down to the joint. As you see here, massive defect. You could plate these and you can graft them, but again, if you've ever seen a gunshot wound to the subcutaneous tibia, it's a disaster. The leg swells up like a balloon. Soft tissues don't recover for a long time. So in my mind, this is a perfect opportunity to do limited internal fixation. You might be able to put a nail down some of these as well. I would agree with Dave that depending on the fracture pattern, you want to bypass all that. A nail might be amenable. This might have been amenable to a nail, except I like the trampoline effect to cover that area of significant bone loss and allow it to heal on its own. And so you see the fibula here, we actually can dial in. Now watch the fibula. We dial in lots of fragments, just like lag screws. You can use olive wires as you gently pull these in, and we can reduce the fibula perfectly to get an anatomic reduction. And you can do the same thing with these metaphyseal fragments as well, using olive wires as lag screws. You don't want to accept a non-anatomic reduction, so you do your best with olive wires to dial these things in. Again, the joint surface looks pretty doggone good. You allow that big defect to consolidate, early weight bearing at 16 months. The joint looks great. Everything is healed, no bone graft, and just small little poke holes. Unfortunately, another gunshot wound, big hole, bad soft tissues, significant comminution. The joint is pretty well blasted. This would be a very challenging plate in my mind. I'm sure our panel could do it, but for me, very difficult. So very similar thing, articular reduction. Again, everything is done in distraction, just like the other speakers. We put a distraction frame on. We let the soft tissues chill out, maybe 7 days, 10 days. Then you can see we've put the rings over the spanning fixator using the fine, thin wires to dial in our reduction, putting a foot frame on to maintain the distraction, at least until we get some semblance of healing. And then I think this is about a 1-year follow-up. The big bone defect healed, a little bit of apex anterior, but overall fairly reasonable alignment, and the fibula is right on. In the worst case scenario, you're able to deform the fracture. You can get some soft tissue closure by deforming, letting the soft tissues heal per primum, and then gradually distract around the pilon to bring these out to length. This was a short segment, not a bad. You could have plated this. You could have done a lot of things. Patient needed a flap. He was a diabetic, bad peripheral vascular disease. Our plastic surgeons ran the other way. And so we basically deformed the leg until we could get the wound and closed it primarily. And then with intentional malreduction, and very gradually over the course of about 8 weeks, gradually pulled it out to length. And you can see because of the distraction, hardly even left a scar. And Joe Shu has described this, as have myself and some other authors. It's a very nice way for the most severe cases of soft tissue problems where they're not flap candidates. It's a nice way to help close some of the soft tissues. This could have been plated with a nail, a plate, what have you. Again, it was the soft tissues that really drove this particular usage. Again, the short segment, soft tissue and bone loss. We like to flap and then place a frame. As you see here, we've flapped, the flap is taken, then we put a frame around it. Plastic surgeons don't like that, but actually it works out very nicely. And you can see as the flap matures, patient starts to weight bear, and very, very nice healing. It's a very powerful tool for failed pilons, and a lot of my practice is because of failed pilons. And this particular gentleman was a 5-time loser, had 2 failed flaps and a big anterior soft tissue defect, and was actually sent for amputation. But he was a military guy, tough as nails, wanted to do one last time because he didn't want to get drummed out of the Air Force. So you can see we took everything out, debrided him. He had a big anterior defect in the face of poor soft tissues, big cavitary defect. And so rather than try to graft him again, which didn't work the first 4 times, so probably wouldn't work the next time, I just bought that. I just actually compressed that area. You can see it's in apex posterior. So we just compressed across that anterior defect gradually so that let me go back here. So here's the defect. We just compress it. We took this and compressed it onto that until it healed. And then, of course, now we've got some malalignment. We do a corticotomy, and I agree with Dave's discussion about reaming. A corticotomy is the same effect as reaming. It does stimulate, causes inflammatory reaction. You get a very nice angiogenesis reaction to the whole leg, not only to the non-union, but up and down. A lot of times with these corticotomies, they'll start growing hair on their toes. It's a very nice way to restart the fracture healing cascade. So I didn't bone graft this. I just compressed across the defect, did a proximal corticotomy, as you see here. and then gradually realigned the overall mechanical axis. So the power of mechanical axis realignment, I can't overstate, both in plates and nails. If the mechanical axis isn't spot on, it's not going to work. So just by realigning the mechanical axis and compressing, we got this defect to heal. It's not perfect, but the guy has gone back to active duty. We didn't bone graft this, just compression distraction made this whole thing heal. I didn't have to worry about his soft tissue. So that's another option that you can do. This is a patient that was sent to me. He had 2 previous plates. Actually, this is before he was sent to me, sent to another outside surgeon with this draining wound. They put an Alizaroff on. And this is probably how not to do an Alizaroff. You can see they basically, it's kind of like an OIF. They X-fixed it in situ. It didn't do any reduction and left it like that. Patient had significant problems, didn't like it, had all his pins were draining. It was really problematic. And they took it off and said, go see somebody else. So they went and saw me with this type of a segment, and very interesting. And there's another possibility demonstrating short segment fixation. So what do you do with this? Do you fuse it? You try to fix it? Well, again, very short segment with the CAT scan, very little bone here. I decided to, let's try it with the frame, but again, the mechanical axis is going to be off. And so I took him to fluoro and we fluoro it. And it's a hypertrophic non-union. It's very stiff, except it's malaligned. Doesn't move a whole lot. So it's a hypertrophic stiff non-union. So essentially what we did was we bought that deformity, compressed it, again, with small wires, and then with an additional wire, we're compressing. So this wire, as you tension it, it compresses the non-union. And that's how you treat a hypertrophic non-union, right? You compress a hypertrophic non-union. So we've compressed it, except it's still deformed. But we're stabilizing the non-union, compressing the hypertrophic non-union, and now we have to use the power of mechanical axis realignment. So we do a corticotomy up above, much like you saw that previous case. And now we go ahead and realign the entire leg with the foot frame, gradually take the foot frame off, let the patient start weight bearing. 10 weeks, the foot frame came off and the whole thing heals. Again, rock solid. It looks a little funky, but the patient went back. She was a nurse and went back to working in an ICU. So a very nice way to take advantage of the power of mechanical axis realignment and the short segment fixation, as you see here. So what about the shaft extension that Dave talked about? Well, you do the same thing with the external fixator, except we can massage this area, we can compress it, we can distract it. The worst case scenario in this case was pretty bad. You see this fragment here, that's that lateral cortex that was shoved out through his heel, came out the bottom of his foot. So that's a problem. And so we put a frame on and then did a proximal corticotomy after the soft tissues calmed down, did bone transported about 4 to 5 centimeters, grafted the docking site, and then looks kind of funky, but actually the joint is pristine, and he went on to continue as an auto repair mechanic. So certainly the advantages are, we've talked about, very simplistic for most periarticular fractures, the overall ability to maintain a gross reduction in the OR, and then you can fine tune these reductions very gradually, especially in cases of soft tissue concerns, neurovascular compromise, and segmental injury. That's a very powerful tool, as I've tried to demonstrate. However, the majority of Pilons certainly can be treated with what the 2 previous speakers with those excellent techniques that they've just described. But certainly under certain circumstances, you should recognize when you need to use these techniques because they are very powerful. So I've run over just a little bit, but thank you for your attention.
So that was ridiculous. I always feel like a bad surgeon when I do these with
awesome.
you guys. That's ridiculous. Yeah. So a couple of questions. Thanks to both of you. That was really something. So one of the questions that came up that I think is worthwhile answering is, when do you go to a hindfoot fusion nail and a bad Pilon fracture? We didn't talk about that at all. We talked about alternative techniques to try to salvage the joint in mechanically and biologically unfriendly scenarios. So when do you choose to go to a hindfoot fusion nail, if ever? Tracy, why don't you go first?
Yeah, I think for me, it would be in a situation where the articular surface is just, you know, a pulverotomy where there's nothing left. And we've all seen cases like that where I could put a ring fixator on it, but it's futile. There's just really nothing left. And especially if we have a lot where there's articular bone loss and there really isn't anything to put back together. So I think for me, it's at the joint. If the joint is deemed irreconstructible, and as both of you have pointed out, you guys can reconstruct some pretty doggone goofed up joints. But when there's bone loss, I think then all bets are off. And so for me, it's the degree of articular compromise would lead me to a hindfoot nail.
Awesome. Dave, how about you?
Yeah, I think articular bone loss of the plafond, but I'm still more inclined to keep their subtalar joint, you know, so I might use other ankle fusion strategies like plating down onto their talus and leave their subtalar joint alone. The few that I've done have really been, you know, I can recall a couple that were hemiplegic patients from old strokes, geriatric. They fall out of the whatever, and they have, you know, a severe plafond injury. And in that situation, I think that's great to do that, and then they can weight bear sooner and try to be more useful for themselves and independent. But I try not to use the hindfoot fusion nail because I think I'd like to keep the subtalar joint if I can. There's always going to be these weird ones, you know, if somebody got like most their talus is gone or something like that. Yeah, sure, you know, I'll do something like that. But,
yeah, good. All right, one more question, and then we're going to take off because we've taken a little bit more time than what we were scheduled for. In the long run, what percentage of the Pilons that you have treated end up getting an ankle fusion? I know this is probably impossible to give an exact answer to, but Tracy, why don't you start with that?
Boy, that's a good question. You know, actually, knock wood, I've been pretty successful. I think as long as I can maintain the mechanical axis, which I think is really crucial, because you can tolerate joint incongruency as long as the mechanical axis is spot on. I would say probably in the bad C3s where you really run into the problems 15-20% of the time, but it takes a long time, maybe 5 to 7 years. So very few of these ring fixators go you know, a year or two. It's more 4 or 5, 6 years down the road before they come to fusion. So they usually do, I won't say always, but they usually do fairly well for 3 or 4 years until they start to, especially if they had an open dislocation where they get chondrolysis as well as articular problems. I think chondrolysis is the big buzzkill. But I must say, if you can maintain the mechanical axis with a nail or a plate or a frame, it goes a long way to tolerating arthritis for sure.
Yeah. Dave, how about you?
I don't even know if I could come up with a number. I would, I'd have to say something like what Tracy just said, you know, I mean, I'd have to imagine that it would be something like that. I think for me, the one thing I've noticed is if they go bad, they tend to go bad fast for me. And so sometimes within that first year to 18 months, their joint is just destroyed. I don't know if it's an indolent infection or if it's just a chondrolysis like Tracy alluded to. And if they don't do that, then they I don't want to say grumble along, they grumble along there for quite a long time. One thing I would say too is that I think the kiss of death is, of course, if you have plafond extension and the talus begins to extrude anteriorly, I think that one's done. That joint is going to be done. That's Steve's teaching, you know, is if you can cover the front of that talus and get the plafond down and keep the talus from extruding, that they can tolerate some joint incongruity of significance for quite a long time. Once the talus starts to get uncaptured, it's done.
Yeah, that's great. All right. Well, thank you guys very much. I appreciate you taking the time to do that. Those are some incredible cases. I know I learned a lot. And so we appreciate all of you for tuning in. You'll all get a copy of this link at least so you can watch the webinar again. There are a lot of things that we covered quickly. Thank you and have a good night.
Thanks, guys. Good to see you all.
Thanks, guys.